Well, good afternoon, everyone, members and guests. And I'd like to thank John and Brent for inviting me to be part of this august group, many of whom, actually all of whom, are my surgical heroes. So, okay, all right, good. I have no disclosures. Sorry, just kind of trying to get this stuff figured out. Okay, so I had the very limited topic of talking about you about Barrett's esophagus in 2017. And so these are the basic topics we're going to discuss: screening, surveillance, who should undergo some type of endoscopic or surgical intervention, what type it should be, and how to prevent post-esophagectomy Barrett's. So let's start off with screening. And the simple answer to this is that screening should not be done for the general population. This is the excellent review article by the American College of Gastroenterology. And the only people that really should be screened are the high-risk groups, which is essentially older white men who are overweight, basically somebody like me. Otherwise, you can also screen people who have had chronic reflux symptoms of more than 5 years or more frequent reflux symptoms. But in general, people don't need to be screened for Barrett's. So I'm going to go over some algorithms as to how I take care of this. After now you identified your Barrett's endoscopically, what do you do? Well, the first thing to do is go ahead and do an endoscopic evaluation, follow with biopsies, because you really want to determine, is this going to be non-dysplastic or low-grade dysplasia versus high-grade dysplasia. That's going to be your primary branch point on how further to deal with this. And I echoed Dr. Swanstrom, use the endoscope, love the endoscope, it is your friend. And the best way to evaluate Barrett's is with a high definition white light. And if you can, no, yeah. So you can see a nice, it's not showing up very well. So I got that. So you see the Barrett's here with the normal squamous epithelium, but use the narrowband imaging liberally. Narrowband imaging really kind of helps differentiate the Barrett's epithelium from the normal squamous epithelium and really makes nodules stand out more. Once you identify Barrett's endoscopically, the next step is to adequately document the extent of the Barrett's. And the way to do that is with the Prey classification. The Prey classification, you measure the length of circumferential Barrett's and then the total length of Barrett's. So you end up with this C and M classification. So in this one, C2, M4, basically 2 centimeters of circumferential Barrett's with 4 centimeters of total metaplasia. The biopsy should be done in the standard Seattle protocol, which is 2 4-quadrant biopsies every 2 centimeters or so. So after you diagnose Barrett's and then what do you do with those patients? Who should be surveyed and how should they be surveyed? And quite honestly, this is a relatively controversial topic as well, not quite as controversial as screening. The first thing to really understand is that there has been no surveillance program which has been documented to actually reduce the incidence of mortality from esophageal adenocarcinoma on a population basis. Having said that, when these lesions are found, they tend to be of earlier stage and are more easily curable. So for your non-dysplastic Barrett's, the general consensus is if you're going to survey them, do it every 3 to 5 years. Certainly no more frequently than that. If you have high grade, these are people that generally need endoscopic treatment, and I'm going to talk about that a little bit later on. There's more controversy when you talk about the indeterminate and low-grade dysplasia. How often should those be surveyed, or even if low-grade dysplasia should be treated? And we're going to talk more about low-grade dysplasia later on as well. So what happens to Barrett's esophagus if you do an anti-reflux operation? Does it regress? And this is a real nice article just recently published in the Annals showing that, in general, you get regression of both Barrett's intestinal metaplasia and even low-grade dysplasia in about a quarter of the patients. The caveat to that is that the fundoplication has to work. And you can see that regression is related to the total time pH is less than 4. If you actually normalize the acid reflux, that's when you're going to have any hope of Barrett's regression. And long term, on the endoscopic findings, it is again, you have to have no acid reflux, the hiatal hernia has to be repaired, and the fundoplication is intact. So the operation has to work in order to have any hope of Barrett's regression. But Barrett's regression is really not our goal. The goal here is to prevent esophageal adenocarcinoma. So how successful is that? Again, here's recent meta-analysis looking at the effectiveness of anti-reflux operations in the actual prevention of esophageal adenocarcinoma. And in general, when you go down here at the very bottom, you have a slightly in favor of doing an anti-reflux operation to prevent esophageal adenocarcinoma. It's more prominent with Barrett's. Having said that, I'm not sure I can stand up here and tell you that I would tell a patient who is asymptomatic that we should do an anti-reflux operation just to prevent adenocarcinoma. I think you'd be creating a lot of post-fundoplication problems without really documenting that it's going to really reduce their mortality from esophageal adenocarcinoma. The American Gastroenterological Association just came out on guidelines or quality indicators on the management of Barrett's. This is quite honest, I can recommend this article. It's excellent for any of those who are interested in Barrett's esophagus, because this really goes through a Delphi process to identify real quality indicators. I highlighted here the next topic, which is radiofrequency ablation is an acceptable method for ablation of Barrett's esophagus with high-grade dysplasia. And I think right now this is going to be the standard of care for high-grade dysplasia, is ablation. So, having said that, what are the goals of ablation? Obviously, our primary goal is prevention of esophageal adenocarcinoma. That's why we do it. But I actually think there's secondary goals that we have to be aware of. One is the prevention of an esophagectomy, because even if the cancer doesn't kill you, the esophagectomy might, or make your life miserable. And two, ablation does improve quality of life. And if you think about the rationale of why ablation should reduce the risk of esophageal adenocarcinoma, it goes like this. Barrett's metaplasia progresses to carcinoma in a stepwise fashion. Barrett's metaplasia is limited to the mucosa. We only need to eliminate those cells which progress to cancer. We don't need to take out all of the organ, only the cancer-prone cells. And this is not really a new concept for us as surgeons. We do this in a number of disease processes where we identify the cells which are at high risk of becoming cancer, and we remove that organ, if feasible, prior to the cancer occurring. So let's go to what I consider the non-controversial area and what to do about high-grade dysplasia. High-grade dysplasia essentially has to be differentiated between the flat type and the nodular type. We're going to go over this a little bit later, but if you have flat high-grade dysplasia, your choices really are ablation with acid suppression and surveillance, or ablation with anti-reflux surgery. If you have nodular Barrett's, that nodule has to be resected, usually with endoscopic mucosal resection, ablate the rest of the flat Barrett's, and then either acid suppression or an anti-reflux operation. There are a lot of different methods of ablation out there. However, I am only going to focus on the bottom three: RFA, cryoablation, and endoscopic mucosal resection. For a variety of reasons, the other ones, although some are used occasionally, are not really ideal. The Halo device, initially developed by the Barrett company, is the one that was used most frequently for ablation with radiofrequency ablation. There are a number of different catheters available. There's through-the-scope catheters. There's circumferential catheters. I'm not going to go through all those details. This is what they look like. This and the amount of radiofrequency energy is just enough at 10 joules to eliminate the Barrett's epithelium without penetrating too deeply into the esophageal wall. That is, you're only eliminating those cells which are prone to develop cancer. This is the original AIM trial, which shows the effectiveness of the ablation. Here's your Barrett's. There, he got ablated with a 360-degree catheter. It creates a big ulcer, and then it heals in, creating a neosquamous epithelium. And this is the article that changed everything. This is from Shaheen, published in the New England Journal of Medicine in 2009, which basically demonstrates a sham control versus ablation, showing higher rates of eradication for both metaplasia, low-grade dysplasia, high-grade dysplasia compared to the control group, and more importantly, the progression from high-grade dysplasia to cancer was statistically significant less, by almost 90% decrease in the cancer progression. This was one of my articles about ablation around the same time. We extended the indications for ablation to longer segments, and with aggressive follow-up and re-ablation of areas that you couldn't see, you could get eradication rates of more than 90%. But again, eradication is not what we're interested in. Eradication is only important if it in fact reduces the incidence of esophageal adenocarcinoma. And what we see here, this is the registry data for RFA of over 4,000 patients. And I'm pointing out this where both for low-grade and high-grade dysplasia, the incidence of progression to adenocarcinoma is about half of what you would expect per year compared to their normal progression rates. And more importantly, the death rate from adenocarcinoma is very low. Most people go on and die from other diseases. And that's what we want to do with prevention. We want to prevent a disease that kills somebody, but you eventually go on and die from something else because, well, we all got to die of something somewhere, sometime. Another option is a cryoablation. Cryoablation uses liquid nitrogen, and it is done as a direct endoscopic technique where you spray the liquid nitrogen on the area of the Barrett's, and then that causes the area to slough off, and you see that there are eradication rates not quite as good, but similar to RFA. The durability of cryoablation is also quite good. You see, like we showed before with RFA, if you pay attention and follow up and touch up any areas that you may have missed the first time around, you can get eradication rates in the 80 to 90% plus rate. Now, what is interesting about cryoablation and why we should probably be aware of it and keep it in our bag of tricks is that it is actually shown to be fairly effective on eradicating Barrett's that has been resistant to eradication with the RFA. And this last column basically shows that you can get almost 80% of patients eradicated with cryoablation after they've failed multiple attempts at eradication with radiofrequency ablation. So going on to a more controversial area is what to do with the non-dysplastic or low-grade dysplastic lesions. And I tend to block these into the asymptomatic and the symptomatic patient. I generally don't recommend a fundoplication for patients who are asymptomatic. And usually we'll put them in an acid suppression with surveillance program. As an old mentor of mine used to say, it's hard to make the asymptomatic patient better with surgery. The symptomatic patient, however, I think you're certainly justified in doing an anti-reflux operation for their symptoms alone. And then you can talk about what to do about their Barrett, since you're going to be taking care of their reflux with a fundoplication. So I was part of this group where we did a review of, or trying to make the case for endoscopic treatment of non-dysplastic and low-grade dysplastic lesions, and we came to the conclusion that it's reasonable to offer patients ablation for non-dysplastic and low-grade dysplastic lesions. Subsequently, this trial got published. And this trial was very similar to the original Shaheen trial, but they focused in on the low-grade dysplastic patients. And they did a randomized, sham-controlled trial. And what they saw is that by ablating patients with low-grade dysplasia, you reduce the progression to both high-grade dysplasia and carcinoma. The relative difference is quite high for high-grade dysplasia and carcinoma, and even just a progression to carcinoma, the relative difference is about 7%. So you do reduce the incidence of carcinoma in low-grade dysplastic lesions. Having said that, this hasn't quite had the same effect on the acceptance of ablation in low-grade dysplasia that it has in high-grade dysplasia, probably because still overall the incidence of progression to cancer in low-grade dysplasia is still relatively small, about 8 per 1,000 per year. So who should you consider ablation in the non-dysplastic patients? Well, this is the group that not only has an increased risk of developing Barrett's to begin with, but also has an increased risk of developing carcinoma. So the Caucasian, male, smoker, obese, young person, long segment, again, remember long segments are more difficult to ablate, and a large hiatal hernia or a family history. However, what is not talked about frequently, but I think needs to be mentioned, is ablation does have a quality of life effect. And that's because people with Barrett's worry about having Barrett's esophagus. They worry about developing cancer. They worry about having an esophagectomy. They worry about having surveillance. It is very much like there's an axe hanging over their heads. And in the patients who got ablated, their quality of life was substantially better than the patients who weren't ablated for the reasons that we talked about. They just didn't worry about their Barrett's anymore. And I don't think that's something that we should ignore as physicians. Maybe insurance companies want to ignore it, but I don't think we should ignore it. So after you ablate somebody, what about an anti-reflux operation? Does that add anything to it? Well, I'll start off with the original article I published in 2009, and then also this is from Swanstrom's group, basically showing you can actually do an ablation and an anti-reflux operation at the same time. So I would go ahead and do the ablation, then while the patient's still under general anesthetic, go ahead and do the anti-reflux operation, and it's very simple to do. You only have to do one case. If you already have an anti-reflux operation, we show that doing ablation doesn't hurt that. The fundoplication stays intact. But more importantly, this is what I want to show you. In patients who had no anti-reflux procedure, their risk of persistent and recurrent Barrett's is actually quite high compared to if they've had an anti-reflux operation. And that makes sense. You're basically eliminating the acid reflux, you're eliminating the bioreflux, your risk of Barrett's should go down. What we also showed in that study is that the length of the Barrett's matters. The shorter segments, not surprisingly, are more likely to get ablated than the longer segments. This is the one that's also more likely to be associated with adenocarcinoma. So the longer segment Barrett's are a tougher animal. And this was this recent published study, and despite the names being very similar to my own, I don't think any of those people are my relatives. But they also showed that the use of a laparoscopic Nissen fundoplication does reduce the risk of recurrent or persistent Barrett's, and it is definitely related to Barrett's length and the presence of a hiatal hernia. So what to do about nodular Barrett's? Nodular Barrett's is this area here, and those are the areas where there certainly is more likely to have esophageal adenocarcinoma. And this has to be approached somewhat differently than the flat Barrett's. I like to get an endoscopic ultrasound on these patients to get an idea of just how deep the lesion might be, and to determine whether it's something that is amenable to endoscopic mucosal resection or something that does require a more aggressive surgical approach. This is one of my patients. We're doing a endoscopic mucosal resection. Basically, use a standard band ligator, find the lesion, create a little pseudo polyp, use a snare to resect it. That's the resected area. There's the specimen down there. You can see the band. Retrieve it and send it off to pathology. And some interesting things happen when you do send it off to pathology. Compared to what you thought you were dealing with, there is a fair number of patients that get downstage and a fair number that get upstaged. So the pathologist having a larger specimen is better able to let you know exactly what type of neoplasia that you're dealing with. And if you're dealing with intramucosal neoplasia associated with Barrett's, doing an EMR and then ablating any flat Barrett's is actually as effective as an esophagectomy. This is a study from Desmeister's group, essentially showing that the survival curves were the same whether they did an esophagectomy or whether they did an EMR and ablation, except for morbidity. Obviously, the morbidity of an esophagectomy is quite high, even in very experienced hands, and this is what I'm saying, that one of the secondary goals is prevention of an esophagectomy. The EMR is certainly very efficacious and durable. This is another systematic review just published this year, showing eradication rates in the 80 to 100% range. What's interesting is that the recurrences tend to vary. This is a fairly labor-intensive and operator-dependent endeavor, so that's why I suspect you see some differences among different endoscopists or surgeons. The overall bad complications, bleeding and perforation, are low, but you see strictures are significant. So this is something to need to be aware of with EMR, because it does make a deeper type of ulcer compared to RFA. Kind of like one of the problems is dealing with larger areas of nodularity, and if you do that, if you approach that with EMR, you would have to approach it in a piecemeal fashion. So in order to make that a little more like a resection, endoscopic submucosal dissection has been developed, where you find a large area, you then create a kind of, again, pseudo polyp, almost like Dr. Swanson was saying with the poem procedure, get it resected, you end up with a fairly large defect. The advantage is that there's a more complete histologic resection, a better specimen for pathologic review. It does have some disadvantages. It's more time consuming, and there's a concern about increased complication. So to address this randomized trial was done, and it was just recently published last year, and pretty much like you'd expect, the time it takes to do an ESD is much longer than EMR. However, the complication rates were about the same. The complete resection rates were better for ESD, and the margin negative resections were better for ESD. Having said that, sometimes you just are stuck and you're going to have to do a resection. And this is a very nice article, which a nice flow sheet that I follow myself. Is despite your best efforts, who really does need an esophagectomy? Well, you're going to have people that do. And that is, despite your best efforts, you have either a positive margin with an EMR, or you just can't get high-grade dysplasia eradicated, perhaps because there's a long segment or something like that. Eventually, those patients may end up with an esophagectomy. T1B lesions, those are the lesions that have a higher incidence of a nodal metastasis. They probably shouldn't even be attempted as a primary EMR. Now, sometimes you find out it's a T1B lesion after the EMR is done because your endoscopic ultrasound may have been off, but it shouldn't be something that you plan to do. And there are some high-risk findings that should maybe drive you more toward consideration of an esophagectomy. One of the problems of doing an esophagectomy on patients who have Barrett's or have adenocarcinoma is recurrent Barrett's in the remnant esophagus. That can occur in about 20 to 30% of the time. So try to address this issue by creating what we call the split stomach fundoplication, where you got your conduit, you split the apex, create these wings, have your little gastrotomy, do your anastomosis, and then wrap the anastomosis with this fundoplication. We've shown that this does decrease the risk of postoperative reflux-related symptoms with regard to an esophagectomy, as well as reduce the leak rate. We did do a follow-up of that to see, well, what happens with Barrett's. We compared a couple cohorts of patients, one with and without the fundoplication, and what we did find is, in fact, what you'd expect, that the recurrent Barrett's in the remnant esophagus was much higher if the patients didn't have a fundoplication compared to having a fundoplication. Interestingly, if you look at the timing of when the Barrett's recurred, 2/3 recurred 5 or more years out from an operation, speaking again that these patients do need long-term follow-up. So I think these are the primary points that I'm try to convey with regard to Barrett's esophagus in 2017. Screening should only be considered in high-risk males, not for the general population. Surveillance of known Barrett's is the standard of care, but there is little evidence to suggest that it does reduce the mortality rates related to esophageal adenocarcinoma. Antireflux operation can lead to regression in a minority of patients. Ablation of Barrett's with high-grade dysplasia is the standard of care and should be considered in all patients who have flat Barrett's esophagus with high-grade dysplasia. Ablation of non-dysplastic or low-grade dysplastic Barrett's is reasonable in selected groups. EMR and/or ESD is the standard for nodular Barrett's, primarily for better pathologic assessment and also for better resection. Esophagectomy is an option when you can't completely eradicate the high-grade dysplasia, or for T1B lesions or high-risk lesions. And you can consider a concomitant anti-reflux operation with ablation, really only in symptomatic patients. So I'd like to thank the Society for the opportunity to addressing you today, and I guess we'll answer any questions.
Thank you, Vic. That was an excellent, very comprehensive talk on a complex subject. I have two questions before we go to the microphone. One is just a clarification. You mentioned that you don't do a fundoplication on an asymptomatic patient with Barrett's esophagus just because they have Barrett's. Can we assume that you mean that someone is asymptomatic as someone who did have symptoms that are well controlled on medication?
Yeah. So if they are off medication and they have symptoms, then I'll talk to them about an anti-reflux operation. Just because then we can potentially get them off of medication. So I don't consider that somebody is completely asymptomatic. I'm talking about the case where somebody does not have any reflux symptoms, was never on PPIs. They got an endoscopy for, for some other reason. Maybe the gastroenterologist needed to make a house payment that month, and you stumble across Barrett's. I'm talking about the truly asymptomatic patient.
Okay, and the second question is, when you have patients with recurrent Barrett's after ablation, so, and I'm not talking about the ablation, you go in and touch up a few areas, but you seem to ablate them well, and Barrett's keeps coming back. What do you do? But it's not dysplastic. What do you do for those patients?
Well, if it's non-dysplastic, and I did a few rounds of RFA, and that's the other thing that's kind of controversial. Nobody quite knows when exactly to stop. How many rounds before you really say that you failed? That's hard to know. Then I would refer for cryotherapy at that point. Sir.
Hi, terrific talk, Prashant Sinha from New York. I guess it kind of this question leads into what you were just talking about. Now that we're performing ablation for high-grade dysplasia, and looking at now the recommendations for nodular Barrett's, are there any situations where you would go to more of an EMR or ESD approach for high-grade dysplasia rather than ablation, aiming to really get that question out of your mind that you really gotten everything?
So are you talking about for flat Barrett's or nodular Barrett's?
For flat Barrett's, where you
Yeah.
have high-grade dysplasia.
So I think here's the trade-off you make. One is that if you have an area of flat Barrett's that might be multi-level, so you got a couple of segments that you did biopsies on that are somewhat separated from each other, and so you're not quite sure what's in between all that, and you just want to get a better specimen. Then I think a EMR ESD approach is very reasonable in that setting. The trade-off you make is that the closer you get to circumferential resection of the mucosa, the more likely are you going to get a stricture.
Phil Leggett, Houston. Really enjoyed your talk. Could you comment, please, on your feelings on Cellvizio confocal endomicroscopy in regards to the future in surveillance and so forth, and potential for making decisions on patients' treatment with that alone?
I'm sorry, so I didn't quite
He's asking
understand.
about Cellvizio. What's the role for Cellvizio, the confocal microscopy?
Yeah. I'm not sure that's ready for prime time. I think that is certainly a very interesting technology. I think it's going to. I'm not sure how much difference it's going to make, but it might. I don't have. There's not enough real world experience out there to really give you a solid answer on that.
Great, thank you, Dr. Velanovich.